We have an expert panel on cancer treatment and diagnosis. We have three top scientists from Canada's top cancer research institute, the Princess Margaret Cancer Centre Research Institute. Now, leading this panel, the institute's director, Dr. Aaron Schimmer, who is both a senior scientist and a staff physician, and also professor in the departments of medicine, medical biophysics, and Institute of Medical Science at the University of Toronto. Dr. Schimmer specializes in acute leukemia treatment and research. He was named Scholar in Clinical Research by the Leukemia and Lymphoma Society and is a past president of the Canadian Hematology Society. He has received over 40 awards and honors, including election to the Royal Society of Canada, American Society of Clinical Investigation, and Canadian Academy of Health Sciences. Now, accompanying Dr. Schimmer is his Associate Research Director, Dr. Gan Zheng, also a senior scientist at the Princess Margaret, and a professor and Canada Research Chair in Cancer Nanomedicine at the University of Toronto. Dr. Zheng and his lab are best known for introducing activatable photosynthesizers for photodynamic therapy and POF-SOM nanotechnology for cancer theranostics. So if you don't know these terms, don't worry, he will explain later. Dr. Zheng is a fellow of the American Institute of Medical and Biological Engineering and a recipient of the 2022 CPAC Professional Achievement Award. We also wanted to have on this panel an expert on lung cancer, Dr. Benjamin Locke. Dr. Locke is a clinician scientist at the Princess Margaret Cancer Center and an assistant professor in the departments of radiation oncology, medical biophysics, and the Institute of Medical Science at the University of Toronto. At the Princess Margaret, he is the staff radiation oncologist within the lung science group. He leads a laboratory program that is funded by Canadian Institutes for Health Research and the National Institute of Health, with a mission to improve outcomes for lung cancer patients by understanding mechanisms of resistance and developing novel therapeutic strategies, particularly those related to DNA repair. So we'll start with a panel discussion. We'll start discussion with Dr. Locke, who will be sharing with us an overview of cancer treatment, followed by Dr. Schimmer and then Dr. Zheng. Then we will go into question and answers. We want to leave enough time for everyone to ask questions. So if you have any question, you can type them in the Q&A. Now, let's start with Dr. Locke to give us the 5 pillars of cancer treatment. I understand, Dr. Locke.
Great, Andy, and thank you to CPAC for this fantastic opportunity to share some of the work that we're doing at Princess Margaret, and also just a bit about cancer treatment, diagnosis, and some of the cutting edge as well. So I am what is called the opening act. So I'm here to just sort of set the groundwork, and I'll actually focus it within one of the pillars of cancer therapy around radiotherapy, which is one of my day jobs. And then Dr. Schimmer will take us through the Research Institute side, some of his work, and then Dr. Zhang, as well as the cutting edge of radiotheranostics. So I trust my screen is being shared correctly. If not, just shout it at me. I have my title slide. I'm going to go on ahead. So I'll start with just setting the stage for the pillars of cancer treatment. There are 5 of them. I'll go from most ancient times, and the first was surgery. When we were first able, or humans were first able to chisel stone into a sharpened edge, some sort of surgery was happening at some point in time, that even thousands of years ago. And then coming closer to the 20th century, radiotherapy was actually the second pillar, having X-rays being discovered over 100 years ago now. And then since then, also its various applications. And I'll dive into that more over the next 5 to 10 minutes of this focused opening presentation. Subsequent to that, we also know about traditional chemotherapy. This actually only came about in the mid-1900s. It was when the first chemotherapeutics were discovered and applied. As we came into the 21st century, close to the year 2000, precision therapy or targeted therapy, where we started to understand more about certain genetic changes within cancer and actually developing drugs and small molecules that can inhibit that led to this era of what we call targeted or precision therapy. And also more recently, around the same time, the more recently applied into the clinical practice over the past 10, 15 years is the fifth pillar, immunotherapy. And you hear about the rest as well. So I'll start with the first two pillars and then really focus on that second pillar. One is that, one thing I'll go back to this slide is that really the mainstay of actually curative cancer treatment is really what we call these local therapies, surgery or radiotherapy. The caveat, however, is that tends to be you need to catch it at an earlier stage of cancer detection and diagnosis. However, there are certain cancer types that can be cured completely with drug therapy, with chemotherapy. Dr. Schimmer does that quite often in his leukemia practice, and also for certain forms of testicular cancer, for example. But for the most part, the mainstay is actually catching it early and then cutting it out completely or irradiating it and killing off the DNA or damaging the DNA of those cancer cells to kill them off completely. So surgery for early stage 1 cancer, this is a standard of care where the current standard is actually take out the lobe of the lung where the cancer resides in case there's tiny cancer cells around it. My surgical colleagues will take out this entire lobe, and the vast majority of patients in this situation can be cured. However, not every patient can go under anesthesia safely or go under the scalpel safely. So we do have an alternative that came about around 20 years ago that we apply very often today, is if the patient is unsafe to undergo an operation, we deliver something called stereotactic body radiotherapy. It's a fancy word for saying high dose, high precision radiation, the same size lung tumor that can shoot in many different radiotherapy beams, all converging around that cancer spot. I can kill off that cancer spot with a 90% plus efficacy rate. Now, I want to dive back a little bit into where we started applying radiotherapy and what it is. So first in 1895, Dr. Roentgen reported on this, quote, new kind of ray. And this was the first radiograph. This is the first X-ray ever taken. This was of Mrs. Roentgen, and this is titled Hand with Rings. So this is dated. This is the wedding band of Mrs. Roentgen. And so Dr. Vera Peters was actually a radiation oncologist here at Princess Margaret, and she reported on the first cures for this previously incurable type of cancer known as Hodgkin's disease or Hodgkin's lymphoma. So before this, Dr. Hodgkins in the early 1900s did these sketches of patients that had passed away and saw all these, the disease involving a lot of the lymph nodes here in this pencil sketch that you can, and this artistic depiction of that. And so this is Dr. Vera Peters, 50 years later, was able to apply radiotherapy to cure many of these patients that were previously incurable. Now let's go back, and I want to take us through the pillar I practice as a radiation oncologist and what stereotactic body radiotherapy is, how I bring a patient through my clinic on the next few slides. So for example, let's say the patient either opted to not go for surgery or was unsafe for surgery. You can see this cancer spot on this chest X-ray. So this is after I met them in the clinic and met with them for patient consultation. Then I take them what we call the radiotherapy simulation, where we take a special CAT scan in my department and to allow me to map out where I want to target the radiation beams and also where I want to avoid. I don't want to put unnecessary radiation to the spinal cord or into airway or into the heart further below. So the simulation, what happens in my department is that we use a standard CT bore, but what's special about it, this table is special. If any of us happen to get a CT for whatever reason that we needed to, it's usually in a rounded table to help hold us in place and be a little bit more comfortable. But for what we need to do in radiation therapy, because we're talking about millimeters of accuracy of setup, we use a flat, hard, rigid table that the patient lies down on, which has these number markings on the side so that we can reproduce the same setup. And the same type of table is actually at the radiation treatment units. So that's the simulation part. At the same time, we also don't want patients moving all around, because how I plan the treatment, I want to deliver that each and every day or each and every session of treatment has to be done in the same way. So we have various immobilization devices that we can reproduce the same exact setup at the day of each treatment session. After I capture the simulation scan, one thing we also think through very carefully is what we call motion management. As you know, the lung is a moving organ. When we breathe, things move in and out. I have this little YouTube clip that hopefully will play over the screen as well. And what this is, I'll point it out for us. This is a person breathing. This is a cancer spot that we're targeting. You can see the diaphragm moving up and down. You can see that cancer spot moving up and down as this patient breathes. So that motion we account for in our treatment planning. We bring that forward. I work with a team of medical physicists and of radiation planning dosimetrists, and we design where the beam should come in, all converging on the cancer spot. We also draw out or let the computer know what are the other structures within the body that we want the computer to avoid sending radiation beams into. The liver, for example, the heart here, the spinal cord, the airway. So that's all contoured out or programmed in the computer. And we allow the computer and work back and forth with various algorithms to ensure we're giving the optimal dose or the best level dose to the target, to the lung cancer target in this case, and avoiding spinal cord, aorta, and other things. Then once the plan is decided, we bring them over to our radiation treatment machine. This is known as a linear accelerator. It's a big fancy X-ray machine. This is where the radiation beam will come out. Notice the same hard table that I pointed out before is also here. This table can move up and down. Some more advanced tables within our department can move left and right and actually even tilt to allow us to get to high precision setup. Our radiation therapists would be in the room for the setup, but they would step out just like you go to the dentist and you get x-rays of your jaw. Everyone runs out before the beam goes on. But beforehand, everything is perfectly normal. And even afterwards, after the beam is done, the therapists are back in just like after the dentist x-ray goes off. A similar type of thing, except this is much higher dose of radiation that's delivered intentionally to kill off the cancer. And that's what we would do. Now, I want to switch gears for the next 5 slides or so to talk through what we've learned from radiation biology from over the past 60 to 80 years. What we've learned is that the target of radiation is actually the DNA inside the cell. And through that, we learned a lot about DNA repair, how our cells actually tolerate damage to our DNA, which happens all the time as we go through a regular life with metabolism that's happening inside our body, with a lot of the complex interactions happening in our cells. Our DNA occasionally gets damaged and it needs to get repaired. And why is that so important is that fundamentally cancer is actually a constellation or an aggregation of various different forms of DNA damage and also different mutations or changes in our DNA sequence, which then allows cancer to take hold if enough of the right ones in the cell sort of unlock the safety locks within our cells that prevent it from growing out of control. But what we've learned now over the past couple of decades now is that we can start measuring and interrogating these DNA sequences. We can learn more about what's actually inside the cancer and different types of lung cancer. We actually stratify them by different molecular markers or DNA mutations, and we pair it up to precision therapy. They have this particular mutation marker. For example, one of the most common ones is known as EGFR. Then therefore, we paired it with an EGFR inhibitor. Now, through this, not just learning about genetic mutation, we have also learned to look at other types of signatures inside the DNA that we're able to sequence or measure. So with that, one of the first cancer susceptibility genes, and one of the more famous ones, is the breast cancer susceptibility gene 1. This was discovered in 1990. And what this is a very important DNA repair gene that works on a pathway known as homologous recombination. That's something I've done in my laboratory studies, and we do a good bit of that today within this area. Where it sort of came to attention over the past 10, 15 years or so is that we know this increases the lifetime risk for a person born with a mutation in BRCA1 or even BRCA2, and therefore leads to really a high chance of developing breast or ovarian cancer. So much so there's some risk-altering strategies. So Angelina Jolie very famously decided to undergo risk reduction surgeries to decrease or to really eliminate the risk of developing cancer in some of these organs that I've mentioned. The other thing we learned is that when you lose function of this type of important form of DNA repair, we can see these scars within the cells or within the DNA of the cells. And something we call genomic scars is that big chunks of the chromosomes, so these are cartoon pictures of the chromosomes, if they're not repaired efficiently with homologous recombination, you can see different arms like moved around the different chromosomes that are close by. And you see this picture of these genomic scars within the cell. We can actually measure these genomic scars by various algorithms. And what's interesting is that this level of this genomic scar feature, so this is this HRD, homologous recombination deficient score, going up, you're more likely to be functionally homologous recombination deficient or DNA repair deficient. What's interesting is you're more likely to respond to certain types of either targeted therapy or certain types of chemotherapy and closer to tumor types that are also mutated in this BRCA1 or BRCA2. And these are some of the studies that show this principle to be true. This homologous recombination deficient type of situation, patients have a double duration of benefit from this cancer treatment, showing that these molecular markers can help us guide therapy. One of the last treatment slides also mentioned about what we can decipher from looking at the DNA sequence of cancer tumor cells is this other type of DNA repair deficiency known as mismatch repair. Mismatch repair, essentially our DNA has two sides to it, two nucleotides. So they sort of stick together. So the A sticks to the T, the C sticks to the G. If you get a mismatch in those, this repair mechanism fixes that mismatch. Sometimes as our cells put in, it thinks it's trying to put in a T, but it's not supposed to be there. It's supposed to be actually a G. This mismatch repair would detect that and try to fix that. Now, in certain tumor types inside that cell, this mismatch repair, if it's deficient, you could imagine many different DNA sequences would be altered. And what's interesting about that, this is a way for immunotherapy to be more effective, because immunotherapy, what it is helping our immune cells recognize more foreign looking things. Actually, it's first meant for like killing off bacteria and viruses, right? But then if our cancer cells become more different than ourselves by having many different DNA mutations that mismatch repair deficient cancers would have, there's actually a greater chance of immunotherapy benefit. So that's what's illustrated here. Patients with tumors that are mismatch repair deficient, so lacking this and with high rates of DNA mutation inside the cancer, what this graph is showing is that each line is a patient, and then each line going down means their patient is shrinking. Their cancer is shrinking to this immunotherapy treatment. This bars going up, and these lines going up, is a patient's tumor that's growing on immunotherapy. And the difference between blue and red is that the blue is mismatch repair deficient, high amount of DNA mutations. Red is mismatch repair proficient or normal functioning, so low number of DNA mutations. Therefore, you can see this dramatic difference in how much immunotherapy benefit is in some of these cases. So what is immunotherapy? I mentioned it briefly, but I'll say what it's really doing, it's targeting, it's antibodies that block certain markers on either the cancer tumor cell here, and the tumor cell is trying to hide from the immune system. So it puts up these, sheltering molecules to say, you know what, immune system, ignore me, don't look at me, just, you don't see me, don't do anything, don't kill me. The immune system is always trying to scan for foreign invaders in our body or things that are different that shouldn't be there. So what immunotherapy is taking the brakes that the cancer cell is trying to push on our immune system to suppress our immune system. We block these brakes that the cancer cell is trying to do. We take that off. We try to supercharge our human immune system. Therefore, is more likely to recognize the cancer cell. So I like to think of it taking this, slow-moving pickup truck, taking off the brakes, and able to supercharge it, and then find more of these, invasive or more foreign-looking cancer cells and kill it off. So I'm ending my presentation here in the next minute. But I just want to end on a couple of thoughts here. Is that we've really entered in what we call the molecular or omics era, where we can really measure a lot inside the cancer cells itself, the DNA, the RNA, protein. Now we can do a lot. And this was just a picture I took before I moved here to Toronto and before I came here to Princess Margaret, of this nice view from the CN Tower. It's our job that we can measure so much, we can map out a lot. But the next challenge is actually understanding what, this particular building or what we've mapped out here, what's actually happening there. And that's a lot of the hard work that many laboratories across the world are doing. I loved my visit to Toronto. Before I moved here, I was walking by the Princess Margaret. I was still finishing my training at Memorial Sloan Kettering. But I loved this banner that was part of the campaign. This was maybe, I think, 8, 9 years ago when I snapped this picture. This banner says, "Why is in our DNA?" And this really captivated me. And that's what my lab chooses to do each and every day, to explore more, to understand, to map out things, to think of new therapies, think of new ways to tackle the cancer problem. So here's my final slide. This is your takeaways from this brief opening presentation, is that there are 5 pillars of cancer therapy. I highlighted very briefly each of them, with a main focus on radiotherapy that I deliver almost every day to my lung cancer patients. And the other brief half of my talk was about what molecular or omics profiling can reveal, both a lot of what we know, but also a lot of what we still don't know. And more these days, it's becoming more and more useful for certain types of treatment decision making, which has been very powerful and a big change in many of our clinical practices. So with that, I'll thank you for your attention. I'll now pass it over to Dr. Aaron Schimmer, who will take over for the next several minutes. Thank you.
All right, thank you, Ben. Let me just try to get my screen sharing here.
Yeah, while you do that, Dr. Schimmer, take your time. I actually see a question that came in, so I'll answer it while you get that going. So don't worry, Dr. Schimmer. I have a question from an audience member, and it reads, "Why choose lung cancer for radiotherapy, not some other cancer? What's the consideration here?" So maybe I'll paraphrase that. Perhaps like, how do we choose what type of pillar to use to treat lung cancer or any type of cancer? So that's a great question. So the considerations are a couple of things. I realize I'm not on video, so I'll turn myself back on, but I was talking to the camera. All right. Couple of things. It's one of the things is what type of cancer it is, and also what stage of cancer it is. For what we call early stage or small cancers that stay in with the organ that they started, we tend to use either surgery or radiotherapy. For example, prostate cancer is a pretty common one. Breast cancer, pretty common. If we catch them when they're still confined to either the breast or the prostate, oftentimes the way to cure it is you either go for surgery, and then for breast cancer, surgery followed by radiation is a standard of care, or a small surgery with some radiation to help make sure that we kill off any sneaky cancer cells that are left behind. And then for prostate cancer, either usually surgery or radiation is interchangeable in terms of curing prostate cancer. That's completely confined to the prostate, though. Very different, though, when we get to cancer that is spread outside of those organs. If they've moved to other places, the prostate, to the bone, elsewhere, then we rely more on drug therapy, or therapy that can go everywhere inside the body. So those are the 2 main things I would highlight: what type of cancer and what stage, essentially where it is in the body, and has it spread or not. So hopefully I answered that question. And I see Dr. Schimmer's slides are up, so I'll pass it over to him.
Super. Well, thanks so much. That was a fantastic overview, Dr. Locke. And, I'd like to take about the next 10 minutes or so to share with you a little bit about Princess Margaret, because, I can't be at an event like this and resist the opportunity to tell you about some of the great activities at the Princess Margaret. And then I'll get a chance to tell you a little bit about the research that I do in my research lab. And the Princess Margaret, for those who you may not know, is Canada's leading cancer center, and most certainly among the top few leading cancer centers in the world. And I recognize that no one wants to be a patient at Princess Margaret. No one wants to have to go for cancer care. But at the same point, I think it's also one of those places that we're really glad to know that if we need it, it's there in our backyard. And at Princess Margaret, we're a center that not just follows the latest in medical advances, but we're the ones developing and setting the new standard of care for cancer diagnosis and treatment. Why am I having trouble? And for some reason, we're not advancing here. All right, let me just try this one more time. There we go. So to give you a sense of the size of scope of Princess Margaret, how big are we? Well, there are 300 individuals engaged in research at the Princess Margaret. These include our scientists as well as our physicians. There are over 400 individuals in various training positions as graduate students and clinical trainees and postdoctoral researchers, close to 900 technical staff occupying over 300,000 square feet of research space and producing over 1,200 publications in the medical literature per year. But I would argue, although that makes us big, I'm not sure that size alone makes one great. And I think what puts us at the lead or at the front in the fight against cancer is, yes, in part the size of our program, but really because of our people. Princess Margaret, in the end, I think, is a story not so much about buildings, but about people. And we have the world's best faculty who've come across the world to be with us at the Princess Margaret and spanning across multiple disciplines, all working together, but tackling the cancer problem from slightly different perspectives. And you've already heard from Dr. Locke, you're going to hear soon from Dr. Zeg. These are two of our scientific superstars, arguably the rock stars of the scientific world, and they're two of many of our world-class clinicians and scientists. I think what also makes us amongst the world's best is our unique environment. It's the ability to have clinicians and scientists at the Princess Margaret work together to tackle cancer and take discoveries made in the research setting and move them into the clinic. We're also surrounded by a tremendous environment of other research institutes, Sick Children's, the Sinai, Women's College, all within just a few minutes walk. Also, we're part of the University Health Network with expertise in cardiology, neurology, etc., all that allows for a multidisciplinary perspective on cancer. And finally, we're unique in that we're all part of the University of Toronto. And so that, which means that within a 5-minute walk, whatever you happen to be working on, there's an expert in the field. And so you're not always needing to reinvent the wheel. And it's this kind of environment that allows for a rapid pace of an acceleration of discoveries. I think also important in terms of what makes us unique is our investment in all streams of research. So we invest in discovery research, which focuses on the inner workings of cancer cells, why cancer happens, why it occurs, why it progresses. We focus on translational research that takes discoveries from the lab and moves them to clinic. And also we invest in clinical research, testing new diagnostics and new treatment options in our patients to set the new standards of care for the patients of Princess Margaret, but also around the world. And you might say, I get why Princess Margaret, it's important to do clinical research. I understand why it's important to take lab-based findings and translate them into the clinic. But you might say, why should a research hospital like Princess Margaret invest in discovery research into the inner workings of cancer cells? And the reason being is that we want to ensure that we're having impact in cancer research and impact on our patients, both today, tomorrow, but also in the years ahead. Because it's the advances and discoveries that we make through fundamental research that are going to produce the paradigm changing diagnostics and treatments that'll take their place in years from now. Because, the investments that we made in research in the last 10 years are what's paying the dividends today in the form of new treatments and new diagnostics. And the investments that we're making today in research is what's going to ensure that we're continuing to make those discoveries for the years ahead. So if you think about where we're going to be in 2030, in just a little bit over 5 years from now, I think that we've set a vision for ourselves that by the year 2030, we're going to be using advanced technologies to detect cancers at their earliest stages before symptoms develop and while the chance of cure rates are higher. That we're going to be using augmented human intelligence, digital intelligence, artificial intelligence to drive faster and more accurate diagnostics to advance care in ways that we can't yet imagine. We're going to develop new treatment options so that cancer, when advanced, will be treated with new high-definition therapeutics, which can ultimately perhaps replace, in some cases, the chemotherapy and radiation that we traditionally give our patients. And we will discover things that have yet to be imagined using, as Dr. Locke described, our deep omic analysis. And finally, we'll have an opportunity to reimagine the cancer experience to better help patients embrace their journey through their cancer treatments by embracing digital technology as well. And again, the share button, I don't know why, has stopped sharing. All right, let me.
You just need to move your slides. You don't need to tap the share again.
Well, it for some reason had paused on me. But anyway, I wanted to transition into telling you a little bit about my research. And my research is in the area of acute leukemia. And this is a picture of acute leukemia on your right, but on the left is what normal blood formation, what blood cells would look like in the bone marrow or the blood factory. And when you look at the bone marrow under normal circumstances, you see a mixture of cells of various shapes and sizes. But when you look in the bone marrow, which is the blood factory located in the long bones of the body, we see more of a monotonous look. And these are all cancerous blood cells called leukemia. And by way of sort of setting everyone onto the same page, you can classify leukemias into acute and chronic and myeloid or lymphoid. Myeloid or lymphoid determines the cells from which the cancer has arisen. Acute and chronic refers to some degree with which the speed of onset. So acute leukemia is coming on rapidly, presenting with symptoms relatively suddenly, and chronic leukemia is being a more slow and grumbling condition. But it also actually reflects the degree to which the cell has become mature. And chronic leukemias tend to be cancers of more mature blood cells, whereas acute leukemias tend to be cancers of more primitive or early stages. And it's these types of leukemias that I particularly treat and particularly study acute myeloid leukemia. And the reason that we're studying acute myeloid leukemia is it's a disease that continues to represent a large unmet need. So when I started my practice and all the way up until 2016, so even before I was practicing for a good probably 35, 40 years, there'd been little change in the therapy of acute leukemia. In fact, in that 16-year period, there was only one drug approved by Health Canada and the FDA for acute myeloid leukemia. It was arsenic, and even that was for a very rare subgroup of patients with leukemia. But yet, due to that investment that I talked to you that we've been making in cancer research, between 2017 and 2024, just in these last several years, we've had 12 new drugs approved, again, highlighting our better understanding of this disease and our ability to translate it into new therapies. And while this, of course, is all very exciting and this offers new hopes and new treatments for our patients, the reality is that in many cases, or sometimes in most cases, patients don't still respond to these treatments. And even though in the majority of, even when they do respond, in the majority of cases, they unfortunately relapse, highlighting the need that we need to continue to develop new treatment options for this disease. And the focus of my lab has been to try to develop new treatment strategies for leukemia. And we've been focused on targeting the energy production pathways in the leukemic cell, and particularly by targeting the energy production hub in the cell, a part of the cell called the mitochondria. And this is it's called an organelle that sits inside the cell, and again is important for the bulk of the energy production in the cell. And one of the ways that we've been thinking about targeting the mitochondria and energy production in the leukemic cell is by activating or blocking an enzyme in the mitochondria called ClipXP. This is an enzyme that's important for maintaining the health and the integrity of the mitochondria, and it's important for getting rid of damaged or degraded mitochondrial proteins. And what we showed is that we've developed a drug, or we've identified a drug, that is able to hyperactivate this enzyme, causing it to become dysregulated and to start to break down or degrade things that normally shouldn't. And when it does that, it goes from something that's supposed to normally maintain the health of the mitochondria to something that ultimately disrupts energy production in the leukemic cell, and particularly disrupts the energy production in the leukemic cell compared to normal cells. So you're essentially producing a power outage, specifically in the leukemic cells, causing the leukemic cells to die. And this drug that we've been investigating and studying is still now currently in clinical trial for acute leukemia, but one that's already showing promising results in a rare form of pediatric brain cancer. And this drug, compared to what used to happen to patients, which is shown in this slide, patients receiving this drug are, at least in the early phase studies, showing what appears to be improved survival and response rates compared to standard of care, and this is now in an advanced stage. And so, in summary, try to highlight for you that I think we're really at the forefront of cancer research. We're at an exciting time that our understandings of the inner workings of cancer cells are now translating into new treatments and new diagnostics. The group at Princess Margaret is tackling this problem through multiple angles, and I've tried to share with you at least some of our strategies looking at targeting energy production in the cancer cell. And so with that, I'm delighted to turn things over to Dr. Gang Zhang again, who's, along with Dr. Locke, one of our scientific rock stars at the Princess Margaret.
Thanks, Aaron, and thanks, Andy, for the opportunity. So let me try to follow up. So Dr. Locke talking about the 5 pillars of the cancer care. What I want to actually to argue, to introduce you a new pillar of the cancer care. It's called cancer theranostics. And theranostic, by definition, is a wordsmith. Is a combine the 2 words, therapy and diagnostic, put them together. That's the word we invented called theranostics. And this is interesting because the idea of see and treat is not a new concept. In fact, it was approved by FDA almost 60 years ago in the 1961 in the form of radioactive iodine-131. We know that iodine is related to thyroid, and iodine is like the target to thyroid. For the thyroid cancer, these amazing clinicians and the scientists came up with the idea using the radioactive iodine-131 to actually form the seeding this thyroid into the in thyroid cancer. Then it will actually form the internal radiation. They will kill the cancers. And what's interesting about this is also the first theranostic pair, what we call now, is because iodine, another radioisotope form called iodine-123, is very good for imaging. So now you are talking about using imaging as a treatment planning tool for the radioactive iodine therapy. So this is the first example of theranostics. But this has been almost, when on hiatus, almost 60 years, because there's no drug has been ever approved since 1961, but until the 2018, where FDA approved the very first modern theranostic, and also Health Canada approved the year after in 2019. So very, very new things. So how modern theranostic works is actually serving as like a magic bullet by targeting the unique property of cancer signatures and using different isotopes. For example, the diagram on the right, you will see there is one biologics which targeting to the PSMA in the prostate cancer, but one has a radioisotope gallium-68. The other one has radioisotope lutetium-177. So the gallium-68 is a very good PET imaging agent and a SPECT imaging. So you can do the PET scan, so you can find the cancer, see what you treat, then followed by the lutetium-177 is a radiotherapy agent that will actually cure the cancer. So typically, this is how theranostic works. You actually, between each cycle of the treatment, you evaluate by the PET scan, see how the cancer is reactive, how the cancer responds to the treatment. So then follow the multiple cycle, you can see the cancer starting to regress. I want to give you one exciting example. That is the 2018 Image of the Year of the field. This is truly fascinating. This is, if you look at this diagram, there's 8 patients, 1, 2, 3, 4, 5, 6, 8 patients. Each patient you do the PET scan of the like the baseline and 3 months after the treatment of lutetium-177. You can clearly see the bone the metastasis through all this one. This is metastatic. This is a metastatic prostate cancer. You can see the dramatic response, and you can actually visualize the response. Because of the image like this, the Cernostics have been very powerful. It was able to approved by FDA 3 years after. In the 2022, the March 2002, FDA approved this for the metastatic prostate cancer treatment. Health Canada approved the same year. Another one for neuroendocrine tumors approved in 2018. Now is the 2019 Health Canada approved. In fact, in the Princess Margaret, these two are now becomes a very important our tool to treating cancers. So I have two more slides. Basically, the excitement of this field is there is so out of the 60 years before the first drug and the two drugs we approved, this field we actually didn't stop. We have developed so many of these radioisotope-based imaging, the PET tracer, PET scan, for all imaging, all different kind of cancer progression. Essentially, almost the entire cancer biomarker hallmarks can be imaging by the PET scan or SPECT imaging agent. So now, with the excitement of Cernostics, we will see the exponential growth by converting many of these imaging agents, like imaging the immune system, and to convert them into the therapeutics. So that's what's very excited field is all happened within the last 5 years. I can almost assure you, that we have take 60 years to approve two drugs, 2018 and 2022. The next 5 years, there will be a lot more drug approved in this because it's a biological targeting, it's a very magic bullet, ability to visualize the target, and its heterogeneity, visualize and using the imaging to personalize the dosing. So the treatment planning and about normally is 1 to 5 treatment. So it's like a new form of radiotherapy, as Dr. Locke has been talking about. And it's a very favorable toxicity profile, and it actually can combine with other treatment modalities. So I want to use the next 2 minutes, final 2 minutes, to explain the Cernostics is a lot more than just radioisotopes. And in our cancer center, we actually have, for example, just one example, how we homegrown these cancer Cernostic. We taking a food, spirulina algae from the Pacific, right? These are the one we're using for the smoothie, and we combine them into a lipid molecule, and we make them a nanoparticles. And that once we form the nanoparticle, it really does it all. So you can do the thermal treatment of the tumor by the thermal ablation. You can do the fluorescence-guided surgery, right? You can do the PET imaging agent. You can do MI imaging. You can do SPECT imaging, and you can do immune therapy, radiation therapy, and the photodynamic therapy. So just to give you a sense, Cernostic field has been under tremendous growth, and we are at the forefront of this. Thank you. I think now we can chat.
Excellent. Thank you very much. That was a fantastic overview by everyone. So now we come to the Q&A time. So if you have a question, just type it into the Q&A. And I'll start with the last part of the Cernostics. What the limitation to this new method?
So what I will say is the imaging has been, like PET scan, we developed so many radio tracers for imaging all the biological process. But because of they are so specific to each process, very target specific, it's very difficult to pushing the translation of these imaging agents into the cancer care, right? But once you're starting to converting these imaging agents into therapeutics, because now you're talking about truly personalized. For each unique biological process or cancer signature, which you can imaging, can be labeled with a therapeutic radioisotope. Now you can do the treatment. So the targeting is coming from the biomarkers. So we take advantage of the full discovery of cancer biomarkers and take advantage of development already existing for imaging them. Now the theranostic field are actually moving them into individualized, personalized treatment.
Personalized medicine is such a fascinating thing to even think about. I guess there's still a long way to go to get widespread personalized medicine. Where are we now? Where are we with personalized medicine? And there's a lot of targeted therapy we talk about in cancer treatment. Can you talk about personalized medicine and also the targeted therapies for various kinds of cancers? I guess anybody can just chime in.
Aaron, you want me to start? Or
Oh, sure, please go ahead.
all right. Yeah, so on a high level, we've both come a long way and have a long way to go. What do I mean by that? One is that we've come a long way in that because we can dive into the molecular features of cancers and look inside of it, we've been able to develop certain drugs that go after that particular change. Now, the most successful ones have been actually one within Dr. Schimmer's wheelhouse, chronic myeloid leukemia. So that was the first discovery of what we call a targeted drug known as a kinase inhibitor against CML. So that was, and the reason why that really changed the game for CML is that many of those patients were not able to be cured. When this came out, over 89% cure rates or really long-term control rates. Now, what also was special about CML, or the ones that were able to be cured or really affected by this targeted therapy, is that the particular DNA change was very unique and also very similar. So it's the same exact type of DNA mutation, and that was a real vulnerability within that particular type of cancer. Now, we've learned in other cancer types, we can sometimes see those very unique single gene changes, like we can call it one gene. And just to remind us, there's 20,000 protein coding genes in our DNA. And then beyond that, there's so many things as well that all interact. And it's not just one gene causes one thing. It's a complex interweb and interaction between all these genes and pathways. So the simpler the cancer depends on one particular vulnerability, the easier it is to target. But as it gets, we've also learned what we don't know is that it gets more complex. So I would say some of the quote unquote easier or more uniquely homogeneous types of gene changes we've been more successful with, and that's been very exciting. I'll list off a few in lung cancer: the EGFR gene, the ALK gene or ALK gene, ROS1. But it's a bit of not diminishing returns. The most prevalent one was EGFR. ALK's a little bit less common. ROS1's even less common. And there's a long tail of very small common ones. So I think that's where the next phase is. Can we catalog more and more of these? And also, many cancers don't have a particular vulnerability that's driving it. It's actually more of loss of breaks. So it's hard to replace a break when it's missing, right? But if something is hyperactive, it's easier to target that. So we've been successful at targeting hyperactive things, and we're also working on ways how to target things when they've lost breaks. So that's probably my opening start to answering that very important and big question. But Dr. Schimmer, see if you have other thoughts to add.
Yeah, I think that's a great way to put it, Dr. Luck. I think what I might add is when you think about personalized and targeted therapy, the classic area would be in drugs, either pills or injectables, that are able to bind and target some of the defects specifically in the cancer cell. Additional newer personalized therapies would include antibodies, which are able, when infused, to seek out and destroy the cancer cells. And now cell therapies, where genetically engineered immune cells from an individual can be, again, genetically modified, reinfused back, and through the genetic modifications, bestowing on them the properties where they too can seek out and destroy cancer cells. A very new and emerging technology now is cancer vaccines, building on the success of the COVID vaccine. We're actually able to use that same kind of technology, the technology that Dr. Zhang is exploring, to prime the body's immune system to again recognize as foreign and ultimately destroy the cancer within it.
Can any of you talk about gene therapy in cancer treatment?
Sure. So gene therapy, the concept has been around actually for decades, but it's probably only been in the last several years that gene therapy has been proven effective. Now, to date, it's being used for non-cancerous indications such as bleeding disorders like hemophilia and other conditions. And the reason it particularly works well in those specific types of conditions is that we're still not very good at regulating how much of that gene is made into the protein, the effector unit. And hemophilia is a perfect example because if you make a little of the protein, if you make a lot of the protein, even making a little is still successful. Even if you make a lot, it's safe. So I don't really think yet gene therapy is ready for prime time, shall we say, in cancer. But the concept, again, using the technology that Dr. Zhang has developed, using the technology based on the COVID vaccine, we're now actually at a point where one can begin to think about using a form of gene therapy to begin to correct the defects in the cancer cell and essentially begin to flip cancer cells into normal cells. Maybe Dr. Zangerlock, if you want to comment on your thoughts around gene therapy.
Yes, I think the cancer vaccine is actually a form of gene therapy, right, in a way. And the cancer vaccine, I think, is now entered the mainstream and giving the essentially the unprecedented, the development speed accelerated by the COVID vaccine development. Now is all the process now shift everyone, shifted focus to the cancer. So I think you will see within next 5-10 years, there is a lot will be new, and it will come up. And just to follow up what I just showed, for example, the PSMA, the prostate-specific membrane antigen, the prostate PSMA-specific radiotheranostics, absolutely a form of target therapy as well, because they are treating these aggressive, essentially the metastatic prostate cancer, which is the traditional therapy, the radiotherapy and the surgery cannot work, right? So these are the ones the cell actually metastasize to the bone, metastasize to everybody, entire body, and you can clearly see why they bring the new hope to the patients. So we're excited in this field, in this era, which we will see so much new form of a target therapy, and we are developing.
So we hear a lot of this term targeted therapy, and I remember looking after a friend who had pancreatic cancer, and I also know people of liver cancer. How available now is the drugs that are targeted to this type of cancer? Can anyone talk about liver cancer and pancreatic cancer in terms of targeted therapies?
I could start us off. I do treat, or occasionally have treated some liver cancer, usually more if lung cancer is spread there. But through that and through what I learned from my colleagues in the gastrointestinal group is that liver cancer is a very difficult one to treat. In terms of targeting it, there have been studies trying to target this pathway that grows new blood vessels inside cancers, or cancer can use to grow that. That's our current best standard of this type of targeted therapy, blocking its ability to grow new blood vessels. It hasn't been as effective as, for example, the targeted therapy against CML. The more recent things that have been helpful for liver cancer is there's been some evidence that adding immunotherapy can actually prolong that benefit a bit more. I think where immunotherapy came on as a really important pillar is that it's really tackling the cancer problem from a different angle, right? We're talking about targeted therapy or drugs that go inside the cancer cells, but then we can only do so much there, or we need to discover more there. The immunotherapy activates our body's immune system. So combining that together, or thinking about it in that way, or actually combining those strategies really led to where immunotherapy is being applied in many different cancers. It doesn't work for every type of cancer as well as we would like, but it has worked for some stubborn ones. Pancreatic cancer, there are certain genetic mutations that are quite common, but those have been much more recently been able to target. KRAS is one of those commonly altered or mutated genes in pancreatic cancer. The other thing that's quite unique about pancreatic cancer is that it's covered by this like fibrous layer. It's very well insulated. It produces a lot of this like collagen and this wall that keeps out a lot of good drugs. So that's where Dr. Zhang's theranostics may be able to penetrate that or really get more higher potent anti-cancer agents like the radionuclides into there. So we're learning a lot from every different cancer type, and it's not cookie cutter where it's exactly the same type of treatments for many cancers all at once necessarily. We have to study it all, and every cancer can be very different. But we're making progress where we can each and every day. But Aaron, seeing if there's any other thoughts around where we can keep moving ahead.
Boy, I don't have much to add. I think that's a great description, except to say I think you're right. Pancreatic cancer remains one of the highly aggressive malignancies, but there are some emerging promising signs around the area of immune therapy and cancer vaccines, even in pancreatic cancer. So hopefully the investments we're making now in understanding pancreatic cancer and its causes is what's going to pay the dividends in the next few years in terms of new treatment options.
So I'm not a doctor, unlike my colleague, Dr. Schumer and Dr. Locke. So I only can speak from the preclinical that, really echo what, Dr. Schumer was talking about. We actually focus a lot. This is exactly the reason why we do the discovery research, because we're not there yet in terms of the translating yet. But in fact, my lab is working with a liver hepatologist, a liver transplant group. We're working on the gene therapies, RNA therapy for liver cancer. We also are trying to, working on the immune therapy project, trying to turn because pancreatic cancer is not responding well to immune therapy. So we're trying to work from the preclinically, try to find a way to turn these immune cold tumor into hot. So these are very exciting discovery research, and takes years before we see them to bear fruit. But this is a very active research area. I would say hope is coming, but not not yet.
Well, hope is always good. Let's turn to breast cancer. It's so the incidence is so high. I heard that breast cancer is very different from a lot of other kinds because it can spread everywhere. And can you explain a little bit about the nature of breast cancer and the spreading and what people need to be aware of it and be careful about?
So I can share about first principles that also apply to breast cancer. One of the reasons why it's we know a lot about it is that it's unfortunately quite common. But also because we're able to screen for it quite effectively. So with mammograms after a certain age, that is often a recommended screening practice by a lot of the public health task force. And it's an organ that is amenable to screening relatively easily. Unfortunately, there's not a good screening approach for the pancreas, for example. They're coming soon, hopefully. There's ways to develop that, but breast screening for screening for breast cancer risk is quite well known. Now, you asked a great question, Andy, about how to think through when we hear about certain cancers that spread, how and why that happens. What generally happens is that for most cancers, breast, lung, liver, pancreas, mostly what we call solid tumors. And then I think later I'll actually ask Dr. Schimmer to talk about what we call liquid tumors or the blood cancers, which might have a different staging system and whatnot. But for most of what we call solid cancers, of which breast is one, it starts at stage 1, mainly inside the breast. And typically what happens, the cancer, if it gains ability to leave its area of starting, if it can penetrate into the blood vessels or into the lymphatic system, that like our lymph nodes are also an area that it can spread quickly through, or there's less resistance to going through the lymphatic vessels or the blood vessels. That's how it starts traveling first. So therefore, the next area that a typical cancer from the breast goes to is the first lymph nodes. So it could start in my breast, for example, and there is also male breast cancer patients and survivors. It could start in my breast, for example, move to the lymph nodes in my armpit or axilla. That's where we detect it next usually. And then from there, that's when often it can then start spreading further. So that's roughly how we do those cancer stages. Stage one is in the breast, for example, and 2 to 3 is more in the lymph nodes. And oftentimes our usual cutoff when it sort of leaves the general area of the cancer, then we call it stage 4, meaning it is spread or metastasized outside of that local regional area. So hopefully, Andy, that answers some of that question for the solid tumors I've mentioned. But I think Aaron, I think in the hematologic spaces could be a little bit different.
For sure. Yes, we tend not to stage in the area of leukemia, stage cancers the same way as one would do for breast cancer. But, one of the things about breast cancer, which I think it highlights, is the value and importance of early detection. And breast cancer is one of those conditions when picked up very early, chances of cure can be very high. But if it's picked up later when it is already spread, then the outcomes, unfortunately, are not as good. And so there's large efforts around the early detection of breast cancer and now many other cancers as well. And when I started on staff at the Princess Margaret, state of the art for the detection of breast cancer was mammograms and other imaging strategies. And while those are still important today, state of the art is becoming detection of minute quantities of the DNA of the breast cancer in the blood. And it is possible now to take blood samples and analyze them for, again, these minute trace quantities of the cancerous DNA as a strategy for early detection. And that's sort of a glimpse of where the future is going to be going in terms of early detection to pick up cancers early when they're more amenable for cure through either surgery or through modalities like radiation that Dr. Locke talked about earlier.
So in cancer treatment, we have the drugs, we have the immune system. How much is the immune system itself that's doing the work? How much is due to the drugs? What are the dynamics between the two sides?
Yeah, that's a great question. If you go back to maybe probably 80s, perhaps 90s, people really didn't think that the immune system was a major player. Certainly you couldn't harness the immune system to attack cancer, and most certainly the drugs that we use today to treat cancer had nothing to do with the immune system. But if you fast forward to today, our thinking on the immune system has changed completely. That that the immune system now is understood to play a major role in the control normally and prevention of cancer, and ultimately cancer arises in part because the immune system is dysfunctional, that the cancer cells find ways of hiding and cloaking themselves to prevent destruction from the immune system. We've now developed strategies in the form of antibodies, of cell therapy, and soon to be vaccines that can harness the immune system and reprime it or reprogram it to detect cancer. And what's really, I think, in some ways very exciting is that many of the classic therapies that we've been using, whether it's radiation similar to what Dr. Locke has been used, some of our standard chemotherapeutic agents, and even some of our newer anti-cancer agents, actually are working through immune-mediated mechanisms, at least in part, where they're producing changes in the cancer cell that allows them to be more recognizable by immune cells. So an exciting time to be studying immune oncology and leveraging those findings into new treatment options.
Can you comment about complementary medicine or alternative medicine? This is a lot of Chinese here. In Chinese medicine, there are certain things. How can they complement and help treat cancer?
So I'm happy. Maybe I'll take it first, and Dr. Locke or Zay, you can follow. I'm sure you get a lot of these questions too, Dr. Locke. I get them obviously all the time, and I fully understand why people wish to pursue complementary therapies, or certainly why they might want to pursue herbal or natural therapies. I think one of the things that one has to recognize about many of these treatment options is that I describe them as unknown quantities, that they come with unknown benefits, but at the same time, unknown risks, because they've not usually been studied in usual scientific rigor. And the challenge that presents is when uses them, especially in combination with standard therapy, and if one is to develop side effects, one doesn't really know then, are the toxicities that you're having and experiencing from this complementary medicine or herbal therapies that you're using, is it from the standard treatment, or is it from some unusual interaction between the two? So I think that for people who are interested in exploring or using those herbal or other therapies, you should make sure that you're having a good conversation with your physician prior to starting that and really fully, assess the risks and benefits of that approach.
Yeah, would be a similar approach I have with many of my patients. The main thing is that, I mean, I very much understand, and on some level, I'm a big fan of what we call integrative or complementary medicine, is how to think through bringing in traditional treatments or traditional approaches to things, or even cultural approaches to things that are very meaningful and can actually make us feel better and really connect us to what's going on. What I would often coach my patients on is that during the active use of well-studied cancer treatments, we do want to avoid unintended side effects or combination effects. So I tend to ask or recommend most of my patients to take on big changes in terms of what they're doing until after we've done the mainstay of our cancer treatment, to allow to provide the best effect and benefits from these treatments that have been well studied, meaning either the drug therapy, radiation therapy, or even surgery for it. And usually I ask them to then add on their other things afterwards as well, if it can help them rehabilitate and build back. One other thing I'll mention is that around where we got to allowed us as medical groups, surgeons, to actually be responsible for people's lives, is that what we are allowed to do and regulate ourselves to do, and also regulated by the government to do, it's ensured that we're doing the best thing for our patients. So meaning, if there's a drug that says that's approved by the regulatory body that screens the drug to make sure it's proven to work, that there's actual scientific evidence to it, that's a high bar to clear. And unfortunately, many of the other, we can say what we want about, for example, my little joke with patients is because they ask, I've heard of this thing on social media or on the news. And my joke is, I could say this bottle of water will cure whatever ailment you have right now, but do we really know that to be the case? So there is a high bar for something to be literally to be able to be prescribed for a patient. And I think for a really good reason, it's to prevent something like that. But it's not to say water is bad. I recommend water to my patients all the time. So same thing with herbal remedies or medicines. It's usually not a bad thing. And I think it's a great thing to take. But just be careful when someone might be claiming it's doing something that hasn't been proven to be the case. So that's the main caution I have for some of my patients.
Maybe the research institute can start some research on the combination of these other medicine combined with the Western medicine. I think I knew the answer to the next question because you kind of answered that. There are a lot of products on the market that say that they could prevent cancer. Are they really promising natural products that help us for this? Dr. Schimmer?
Well, I think it'd be a similar answer, right? That in many cases that they are unknown quantities with unknown risk, unknown benefits, and unknown interaction with your standard therapy. So, if this is something that you want to pursue, definitely do it in consultation with your physician. And I think, Dr. Locke, you also provided a great way of framing or thinking about some of the claims around those treatments.
One thing I'll also continue and add a little bit on is that actually a lot of our current treatments today, a lot of medicines were actually natural products in nature first. Aspirin is actually from tree bark. It's a natural product. Penicillin was discovered as a mold. So really what medicine is that is actually from the earth. It is natural, except now we've been able to purify its most active components and making sure it's of high quality and not contaminated by dirt or other molds that we don't want, for example. So that's where really technology has advanced for us, and why medical products and drugs are manufactured in very clean and safe facilities for that very reason as well. So that's one thing I want to say is that some of our best medicines today started as herbs or tree bark or mold. And that's actually a lot of the inspiration for where a lot of the drugs are today. And we're sort of building upon that. Mother Nature really is a genius in many respects. And then we're just sort of harnessing and learning from the world around us.
Now, one more question about breast cancer. A lot of people, they get treated and it seems cured, and then after a few years comes back. When that happens, what is the success rate in terms of treatment and recovery?
So I can start with that. So it'd be quite similar to how it first started in terms of success rate. If it, for example, very rare cases, it would regrow back exactly where it started. Let's say it started in the breast only, had a surgery there, had radiation there, but right at the edge of the surgical cavity, it started growing back a couple of years later. But it only grew there. The surgeon could decide to go in, this is the time to actually remove more of the breast or remove the entire breast, for example, and potentially that patient where that breast cancer occurred only in the breast can be cured. Unfortunately, that's a rare type of recurrent situation. Oftentimes, if and when cancer comes back, it's actually more likely a sneaky cancer cell has already left the breast and has already lodged itself in a bone somewhere, even when we first treated that patient. However, one tiny cancer cell we can't see by PET scans or CT scans. One tiny cell is microscopic. I tell my patients to even see a very tiny nodule, a very tiny spot, smaller than a marble or pea size on our CAT scans. It literally needs to be 10 to 100 millions of cells to be able to be seen. So you can imagine just one cell already sneaking away. And that's actually the more common cause of cancer coming back. Some cell that was kept in check by the immune system, over time it outgrows it. And unfortunately, if we're in that case where it's spread, then we do rely more on drug therapy to try to control the growth of those cancer areas in various parts of the body for as long as we can. But unfortunately, in terms of curing a patient in that type of situation, that is quite rare and not an expectation that we generally communicate to patients in that situation. So hopefully that answered part of that. I mean, Dr. Schemmer, seeing there's other facets you wanted to add to that.
Yeah, I think you're right that, unfortunately, when the breast cancer recurs outside of the breast, it's becoming a much more challenging condition to treat. But where I think there is hope and promise is that over the last several years, we've seen dramatic advances in the kinds of therapies that are available for those patients, again, in the forms of drugs, small molecules, antibodies, or immune therapy. And that's fortunately allowing patients to live longer and live better than they did just several years ago.
Right. So let's talk about detection and prevention. What are the early screening method available now for various cancers, so we can discover them much earlier than when it's too late?
So there have been real advances in the early detection space, and Dr. Zhang's going to have him talk a minute about what really the cutting edge may be for his lab. But the mainstays of cancer detection are still important: mammograms, colonoscopies, pap smears, prostate cancer screening with rectal exams, PSAs. What is important to continue to do those with your physician at your regular milestones. In addition to those things, I think where we're going in advancing is with novel imaging agents to see small, minute amounts of cancer that you might not normally be able to detect. And we'll get Dr. Zhang to comment on what he sees the future of that being. But in addition, a very exciting area is what we're calling liquid biopsy. So this is where one can take a sample of blood and in the blood find minute traces of the DNA or the genetic code of the cancer cell, and not only be able to tell you that you have early stages of cancer, but most importantly, where it's located. Because of course, to tell someone, yes, you've got early stages of cancer, but we don't know where it is really not the least bit helpful. What they've got to be able to do is tell you where you need to look for it, where to find it, so you can then follow it up with radiation and surgery. But Dr. Zhang's work really in part focuses on this concept of early detection.
Right, Dr. Jen.
Yes, so maybe just another, expand a little further. As we're going forward, we're also trying to not just early detection, the early not necessarily means size of the tumor, right? It's really as it depends. For example, can you separate indolent tumors, cancers, from the aggressive form of cancers? Like for example, the prostate cancer probably the best examples, right? So some of the cancer you probably just want to leave it alone because they are not going to causing too much damage. But I think as we going forward, more and more these molecular signature, what we so-called molecular imaging, right, is really give us a chance try to separate these most aggressive cancer type at early stage. I think that's probably the future, right, Aaron?
Yeah, I would agree.
Let's talk about prevention. Now, what kind of lifestyle and other things that tend to exacerbate things and causing cancer? What type of thing that we can do to reduce the chance of developing cancer? We can talk about that, every one of you.
Maybe Dr. Locke will turn that to you for starters.
Sure, I could start us off. Or Gang, you want to start?
I'm not doctor.
You are a doctor. You got your PhD. I'll briefly start. It's what I would say is to do everything in moderation. Keep up with your general activity level. Exercise is really helpful. We do know that also, keeping a healthy weight can also reduce certain types of cancer. So exercise is important. In terms of diet, I would say well-rounded diet. And also just avoiding things that are known to be, that would increase your risk of cancer, or certain toxic habits, including tobacco use, or smoking, vaping, that would also increase our risk of lung cancer, for example. So the general things we do here in public health, what I would say is I know there's a lot of push to say, if I understand even for myself and for many of my friends and loved ones, is we all want to feel like we have a sense of control. So if I keep doing this one thing, it will ensure this won't happen. Unfortunately, with cancer, for the most part, it is, many of my patients ask me, like, why did I get this? I would say the vast majority is simply bad luck, in the sense that the cell had acquired enough, loss of its brakes and its, safety checks, that it turned into cancer. And is that nothing directly my patient had done? For example, we know people that smoke literally, thousands of packs of cigarettes that don't develop lung cancer. It's only a risk modifier. Rarely do things guarantee a certain outcome. But that's what I would say is good, healthy living, things in moderation, would put us on the lower risk scale of things that we can control.
Dr. Schimmer.
Fantastic description. I have nothing to add to that. That's well described.
All right. Okay, you have anything to add? No? All right, our last question. I want to know how to avoid getting cancer, and are there any books, websites, and a YouTube channel you can recommend? Yeah, I'm sure everybody can do that.
There's a fantastic amount of material now on the internet. There's a lot of great sites, a lot of great resources. Unfortunately, there's also a lot of misinformation, poor sources, and bad advice. And so really the key is searching out reputable sources. There are many reputable sources. Some of the examples would be the Canadian Cancer Society, the National Institutes of Health, and in the case of blood cancers, the Leukemia Lymphoma Society. And that really is ultimately the key, is making sure you're getting your information from the right, reputable, vetted sources.
Anything to add, Dr. Locke?
Actually, less on prevention, but one interesting resource or source, or something that I found very helpful to learn about the history of cancer, to learn more about how the treatments came about, and that may be able to inspire some thoughts about demystify how we think about prevention as well. It's actually this, I think it was Pulitzer Prize winning. It was The Improbable Maladies, is a book by Dr. Siddhartha Minherji. It was a fantastic read. It was the 2011 Pulitzer Prize. I just pull it up on my browser here. So that takes, I really enjoy, it's a quick read. I remember reading that maybe, soon after it came out, and I really enjoyed it. And it's actually very accessible language. It's written in a way that I think can be accessible. And that might also learn more about what is actually causing cancer and can help us think through what can we do about healthy living to prevent it or discover new ways to tackle it and think through it together. So that's one recommendation I could leave for us.
Can you see that title again?
The Emperor of All Maladies, Maladies. So,
all right. Thank you. Dr. J, you have the last word.
I learned a lot too. So thanks to my colleagues.
Well, a big thank you to each of you for taking the time to come on a Friday night to share with us all this useful information. It's, I learned a lot. I'm sure everybody else learned a lot, and it will be very helpful. So thank you again for doing this for us. And I wish everybody a good night and have a great weekend. Goodbye.
Thank you. Good night.
Goodbye. Thanks so much for having us. Bye now.
Thank you.